You may have heard a lot about the immune system as it relates to what infections, coronavirus or bacterial infections. Now we're talking about the immune system as it relates to heart disease. So it shows how these diseases are very common and they have a common relationship. So it's not much different than someone who has systemic autoimmune disease or someone has systemic inflammation from systemic heart disease due to inflammation as well. So activation of the innate immune system can again trigger these surface molecules. We call them pattern recognition receptors, but basically these are surface molecules. The common one on the heart is TLR4, but these are molecules that can determine a signal whether the cell is inherently damaged or whether the cell has been taken over by a pathogen. You have DAMPs or PAMPs. The names are not that important, but these are cell signaling molecules that signal damage to the cell. That triggers more inflammation, more inflammatory cells that come to the site. So you have this cascade of more and more inflammation that's being triggered. So chronic inflammation begets more chronic inflammation is the point we're showing here. And again, stresses such as ischemia. What is ischemia? Ischemia is inadequate blood flow or oxygen delivery to tissue. So if you have poor coronary flow, if you have arteries or endothelial cells that are impaired, and so the arteries don't dilate and deliver oxygen, so you have less oxygen delivery, more ischemia, perpetuates more inflammation. So there's this negative cascade of events that happen that causes more inflammation, more oxidative stress, which then triggers more ischemia and the like. So oxidative stress, let's go over this real quick. As I said, it's an imbalance between molecules that are considered, say, free radicals or reactive oxygen species. They're unbalanced with antioxidants. So what effects does this have on the heart? Well, it can have electrical effects on the heart. So excuse the complexity here, but essentially reactive oxygen species increases the amount of influx of calcium inside the cells. This results in arrhythmias such as atrial fibrillation or other atrial arrhythmias. It can also cause sodium channel abnormalities, which can result in ventricular arrhythmias. So people that you may know who have atrial fibrillation, who are on blood thinners or other medications, well, the mechanism here can be triggered by excess oxidative stress. And so if you do things to reduce oxidative stress, you can then do things to reduce these arrhythmias. And we're going to talk about these mechanisms that we're going to look at in some of our studies and also in some of the clinical patients that we're going to discuss. There's also other molecules, ryanodine receptor 2. Again, more calcium influx. This can lead to contractile dysfunction. The ability of the heart muscle to contract or relax can be impaired by excess calcium overload inside the cell. Furthermore, you can have mitochondria damage, which is secondary to ischemia, which then mitochondria releases more reactive oxygen species. Also, mitochondria are the energy cells for the body, so ATP production can be impaired. So some of these ATP-dependent biochemical reactions can be impaired. So increased reactive oxygen species can also directly lead to increased fibrosis. So as they said, a picture's worth 1,000 words. And summary of what I just talked to you about. Number one, electrical disorders can come about through increased oxidative stress. Number two, you can have abnormalities in the sarcoplasmic reticulum due to increased calcium inside the cells that can affect contractile function, systolic or diastolic. Three, you can have mitochondrial dysfunction related to reactive oxygen species. This can impair mitochondrial function, i.e. reduce ATP production efficiency, but also cause more reactive oxygen species release. And number four, direct fibrosis development as a result of oxidative stress. So I just wanted to give you the background from a mechanistic standpoint, because we're going to discuss how do you connect food with improved cardiac function. And I want to just give you a background because we want to talk about some of these mechanisms. We talk about some of the research that we have done and some of the research that we're planning. So plant-based nutrition. What are the general benefits? I'm not going to spend a lot of time on this. As I alluded to earlier, many of my colleagues will talk about the general benefits of plant-based nutrition. I think a plant-based diet is a superior diet, but which plant-based diet is going to be an important one to differentiate. I shared just this one article with you where they looked at a low-carb diet from plant versus a low-carb diet from animal sources. And this is in patients who had prior myocardial infarction. So among people who survived myocardial infarction, greater adherence to a low-carb diet and high animal sources of fat and protein was associated with a higher all-cause and cardiovascular mortality after MI. So is one long study. There are other studies that show survival benefit favoring plant-based diets, but I just want to lay that background in my discussion, because as I go forward, we talk about optimal nutrition. I'm going to be talking about a plant-based diet. So it's not a matter of whether you should eat a plant-based diet or not, in my opinion. It's a matter of which plant-based diet should you eat and the details there. And that's what we're going to get to when we talk about the food prescription. So nutrition for the acutely ill, can nutrition have an impact? So as I alluded to before, as the other study alluded to, it's great to say, eat a healthy diet and over time you'll be healthier. You can exercise, et cetera. And I think we inherently know this, especially in people who are out and about. But what about someone who's having a heart attack, or someone who's in the hospital, they're in the ICU, or someone who is acutely ill in the office? Can this nutrition have an impact in a matter of hours, days, or weeks? And that's what we want to learn. And what I want to do is I want to share some clinical case presentations and walk you through how I use this in my practice, and my patients who are in the ICU, the CCU, who are in our office, who are acutely ill. And I want to walk you through how this process goes. So let's go start with our first case. This is a patient with cardiac amyloidosis. Cardiac amyloidosis is what we call an infiltrative heart disease. It consists of usually a genetically predisposed condition where you're making excessive abnormal proteins, sometimes light chains and other proteins that malform and can infiltrate different organ systems, the heart being one of them. So this patient is a 62-year-old man who we had been treating for some time, and he began having some problems with some tachycardia, had some arrhythmia. His ejection fraction on echo was about 25 to 30%. On the previous echo, he had a history of pulmonary emboli. Even prior to coming to our practice, he had had pulmonary emboli and deep venous thrombosis. He had been on blood thinners before and had some issues with different ones. Had a history of hypertension. We had suspected cardiac amyloidosis prior to this hospitalization that I'm going to discuss, but it had not been confirmed until subsequent to this time. So I just put this in the note, suspected amyloid cardiomyopathy, but it was confirmed by previous studies. What I want to do right now is I'm going to put a pause on my screen share, and I'm going to bring up an echocardiogram to give you an idea of what his heart looked like. Hold on one second. This is where we test my technical skills in the program. And okay. All right. So y'all let me know if you see a diagram. Oh, hold on one second here. This is not his heart. Hold on. Okay. Y'all see heart moving? Can somebody just let me know they see a heart moving? I'm going to go on with the discussion. So this, I'm not going to show too many details. This is the left ventricle, and this is the walls. This is very thick. Now, I know many of you are not accustomed to seeing these ultrasounds of the heart. Some of you are. This is the left atrium. You have the aortic root here, the right ventricle there, and there's a little bit of fluid back there, a little fluid around the posterior part of the heart. And this heart is enlarged, it's very thick, and it's not moving very well. I'm just going to go through different parts of it. Here's an M mode. This should show like a sine wave, okay? And it's just barely, it's almost straight. It should go here and here to show contraction, but it's not showing a lot of contraction at this particular time. Now, the amount of contraction can improve or worsen. Here's a donut part of the heart. You see this part is thickening here, but this part is not moving very much. Here's the right ventricle, the left ventricle. See how thick this wall is? Very thick. That's hypertrophic. It's not hypertrophic cardiomyopathy, but it's hypertrophy due to the infiltration of the amyloid in the heart. You got fluid around the heart. That's what this little black area around here is. There's some fluid in the front part of the heart there. I'm just going to show you a few images there. So I'm going to stop my screen there, and I'm going to minimize this. Hold on 1 second. Now, so basically what I want to do is continue with his case discussion. So there's a picture of the patient's heart. And so he had several months of what we call claudication, of pain in the left leg. He had pain in both legs, but much more severe in the left. And it just got progressively worse. And he presented to our office with worsening pain, and he couldn't walk about 10 yards. So we did an ultrasound, a Doppler study in the office, and found that one of his arteries on the left was occluded. And we didn't see pulses in the left leg. So this constituted an emergency to admit the patient to the hospital. So we did admit him. He underwent some medication adjustments and diuretics in the weeks leading up to this time, but he had an occlusion to the leg. We noticed heart rate upon admission was in the 100s. The rhythm was an atrial flutter rhythm or atrial tachycardia. They cannot get Dopplerable pulses in the left lower extremity, but they were able to get him on the right. His kidney function was a little bit abnormal from baseline. His potassium was lower. His B-natriuretic peptide was in the 500s. I'll discuss that a little bit later. So on the 22nd, he was admitted to the IMU, started on intravenous heparin. I called my interventional cardiology colleagues. Peripheral angiogram was done, and was found to have multiple acute thrombi and, of course, an occlusion in the SFA, superficial femoral artery. Based on that angiogram, we decided to call the surgeons, and he was sent for an emergency surgical thrombectomy. What they did is went in, surgically removed the thrombus or the clot. They saw some vessels that needed to be bypassed from the femoral to the tibial artery, with more clot being removed. So it was a pretty extensive surgery. Lost about 1 liter of blood, had to have some crystalloid and albumin given. He wasn't transfused immediately at that time. And I'm going to walk through some of the nuances of the hospitalization, because I think some of this is important, because the thing to take from this, and I'll walk you through it, I don't want to overwhelm you with the details, but I want you to get a feel for the level of complexity and the number of problems that we're dealing with when we have a patient who's acutely ill. Many of you who are pretty healthy may not have been, acutely ill before, may not have had a loved one, but these are some of the things, at least this is from the backside of the scenes, in terms of how you're dealing with it, what you're doing with an acutely ill patient. So his kidney function, as I said at the beginning, was abnormal from baseline. We got a nephrologist involved. There was transit loss in some of the pulses in his feet. They got an emergent CT angiogram. Now, again, the CT angiogram, they use contrast. Now, here's somebody with compromised kidneys. You give them contrast, which can further compromise the kidneys, but you're doing it emergently because there's a concern about the loss of his pulse. Now, again, when someone loses a pulse and loses blood flow, that constitutes an emergency because they could potentially lose that extremity. So you're doing a lot of things for the patient that could potentially harm him in another way, but you're sort of doing it in an urgent manner. So he was able to move the foot more after he got more pain pills. The pulse did come back magically, however, and it could have been spasm in the artery. Who knows? So the surgeons were managing him. Of course, we were managing him on the cardiovascular side. He was given a unit of packed red blood cells because the blood count was low. You try to minimize the amount of blood you transfuse on these patients, but I don't like a low blood count on somebody with some peripheral vascular or any coronary vascular compromise, because they need the red cell carrying capacity. So hemoglobin of 7.8 in a patient like him with a resting heart rate in the 100s was too low. So we gave him some blood. Later on, he got more blood. Now, things started becoming more problematic on the next day. His creatinine continued to get up, go worse. And I'm going to show you graphs of these labs at the end of this discussion, at the end of this section of the presentation. His lactic acid. So basically, we measure lactic acid, see how much acid is building up in the blood. The more acid's building up in the blood, that tells me the less perfusion. So if you're not getting oxygen delivery to your feet, your toes, then you develop acid buildup because you're not able to clear acid and remove the acids buildup due to normal metabolic activities. And so lactic acid buildup, it was fluctuating, it was up and down, but there was something that was concerning us because we were concerned about blood flow. His hemoglobin did come up after the packed red blood cells transfusion. He was getting more pain medications, even more blood because he started bleeding from the wound. We were trying to give him heparin to anticoagulate him, but that potentiated more bleeding. Again, you're doing one thing to help him in one way that harms him in another way. And so you have to back off. And so we had to hold off on the heparin. He became hypotensive. We started on norepinephrine. Again, starting norepinephrine makes the heart rate worse because he has an arrhythmia. It also can constrict blood vessels, but we had to get the blood pressure up. So we're dealing with this delicate balance of things. They tried to stitch the bleeding closed, but that didn't work. And one Saturday morning, I walked in and the patient had numbness and no pulses in the leg that they had operated on, and it was swollen. And that was the immediate diagnosis we made of compartment syndrome. So we called the surgeon. They jumped right on it. He was a little bit agitated. There were a number of other things going on. So they took him back to the OR to open up that wound, to release some of the bleeding. I called my colleague to evaluate him for EP. I'm an electrophysiologist, but I actually have her do all my procedures now because I'm focused more on nutrition and wellness. So she agreed to take him for an atrial flutter ablation the next day. The surgical team talked about calling advanced heart failure, but I felt it wasn't necessary because I think we just need to get his heart rate and rhythm under control. The surgeons took him back, evacuated the blood, and things improved. So he had the wound wash out. There was a wound vac placed to drain that wound area, to keep it from swelling. He went to the cath lab and we got rid of the atrial flutter. There was an atrial flutter ablation. This is going to deem to be very important as I go through the summary. And so on the 27th, we started the nutritional detox. Now, all of this stuff going on, you got surgery and imaging studies and procedures and all. And I discussed detoxing earlier. There was some back and forth between the nephrologist and I had to let her know that I'm the attending physician. And, we had a little bit of fighting there, but, everything got straight and we were all friends. But the long story short, we had tried to start the detox a day or two earlier. There was some confusion. It was started without interruption on the 27th. That's an important thing to know. So you had the atrial flutter ablated here. The nutritional detox was started here. What do I mean by detox? And I'll show you some images of the food, but we put them on raw fruits and vegetables only. We had superfoods of blue-green algae. We put a super green powder added to smoothies. Who have salads and wraps. He drank coconut water and a number of other things. So the creatinine at this time was almost 5. The nephrologist was concerned. She and I agreed that we wouldn't start dialysis right away. We would hydrate, get his hemodynamics under control, because I think most of this was due to the heart failure with the arrhythmia. So he received more packed red blood cells and more diuretics. So after about 24 hours of this, things started to turn around. Okay, he did have a urinary tract infection they picked up on. They addressed that. An echo was done. His heart was beating at less than 20%. And you saw an image similar to the echo that we did here. Severe thickening of the heart, no blood clots inside the cardiac chambers because we had to stop the heparin because that was important to know that there were no blood clots there. A little bit of infusion. By 2 to 3 days, 3 days after he had the ablation and started the detox, there was still some edema, but he was okay to get up out of bed. We held his beta blocker medication because of the transient hypotension he had, but his blood pressure was holding on its own without the beta blocker therapy. And his heart rate actually was under control after the ablation. So he was stable to leave the ICU and went to IMU. So he had recovered enough to go to the step down unit. He continued to do well by the first of the month, This is just a summary of the things that happened over the course of the last few days. So we're about 4 to 5 days after the ablation of the arrhythmia and also improvement of his diet with the detox. So on day 4, which was about 8 days after, he was able to go home. So what happened in this hospital course? I went through a lot of nuance with you on this patient, but I want to give you some data to show. If we look at his creatinine, we saw the creatinine went up, and this is a sign of abnormal kidney function. Glomerular filtration rate is kidney filtration rate. It went down. This is a time when he was acutely ill after surgery. He went into surgery on the 24th, and we were dealing with these problems of bleeding and low blood pressure, and all these things contributed to the low kidney function, which already was low when he came in. And so it got worse. Also, we gave him contrast. The nutritional detox started between these 2 days. The ablation started here. And after that, his kidney function started to improve with improved cardiac function. The lactic acid built up. It then dropped. And after here was normal. Liver congestion also peaked when you had poor cardiac function. So all of these things peaked when he was acutely ill. And we also see the white blood count is a sign of inflammation. So increased inflammation, decreased cardiac output, increased inflammation here. And you see the inflammation going down. But notice the inflammation didn't even normalize even when he went home, because he still had an open wound that we were managing. Albumin level drops because of increased inflammation. So in summary on this patient, to put all this together, I know I went through some nuances with you, but what were the key reasons for this patient's decompensation? Well, one, he was on a plant-based diet. This patient was followed by us, followed by my PA. However, he was eating a fair amount of cooked foods. Maybe some might have been microwaved, I'm not sure. But he did take some kind of an over-the-counter herbal tea I didn't find out about until later. And he went into this atrial arrhythmia. This really led to a compromise in his cardiac function. This also probably contributed to the embolization and occlusion of the artery in the lower extremity. And the need for surgical and intervention also led to further compromise. Key reasons to recovery. Well, we got to him urgently. So the surgery and revascularization was important because that took away the ischemia in his leg, which was triggering more oxidative stress, more inflammation. But also we ablated the arrhythmia, which compromises cardiac function. But also key to this was his nutritional detox. We put him on raw fruits and vegetables. Now, one thing I didn't point out is that his medication list was very, very minimal. And so we were able to control his heart rate and blood pressure with just nutrition without him being on 5 or 10 medications. He was already on a plant-based diet coming in. That was also to his advantage. And all we did is just dial it up, made it more refined and more anti-inflammatory. So let me go on to case 2. This is a patient with severe mitral valve disease. And her hospitalization is a little bit less complex. She's a 66-year-old lady with heart failure. And her predominant problem was severe mitral valve regurgitation or leaky mitral valve. She had what's called an interventricular conduction abnormality, which also can worsen heart failure symptoms. So we had been managing her as an outpatient. She was also on a plant-based diet, but she was eating a lot of processed plant-based food. So while I talk about a plant-based diet being, I think, the superior diet, it's important in terms of how you're applying that, how you're preparing the food, where you're getting the food from. So any vegan diet, all vegan diets are not created equal. As she was on a vegan diet, now she may have splurged to vegetarian, may have had some eggs from time to time, but the long story short, despite having a relatively healthier diet, her condition progressed because of its advanced nature. Let me pause and show you her echo real quick. Okay, I'm just going to go through and show you the amount of leaking. This is the left ventricle. This is the right ventricle. See this left atrium. You may remember the other picture. This chamber here was much smaller than what you're seeing here. This left atrium is huge. It's bigger than the left ventricle. And so that's abnormal, just to let you know that. I'm just going to go through and show you a couple of images. you see all of this color, this mosaic color going in. This is blood leaking back in the left atrium. So the severe leakage of blood back to the left atrium, the blood's supposed to go from the left atrium to the left ventricle. A lot of blood's going the opposite way. It's going the wrong direction. So that chamber is very large, and that's why you see the chamber be very large. I'll just go through a few other images here. You can see the foreshortening, short chamber. Let me just show you, so again, more regurgitation there. Tricuspid valves regurgitating. I'm going to try to show, this is a 4-chamber, left ventricle, left atrium, right ventricle up there, right atrium. And you see here, the left ventricle, see how much blood's going back. There's a little bit of leaking going back here, but it's severe. It's going all the way back and just filling up that chamber. That was the major problem. And she had some restrictive impairment. So I'll stop my screen there. So now that you're all experts in reading echoes, we will go back to the presentation. But I want to give you a glimpse of what we're dealing with in terms of her cardiac condition. So this patient progressively got worse. We admitted to the hospital and started on intravenous diuretics. And the plan was to have her stabilized in the hospital. I was going to call my colleagues in interventional cardiology, structural heart, to look at possibly doing what's called a mitral clip to repair that mitral valve in a minimally invasive way. We wouldn't have to open the chest. She wasn't a candidate for that. She had a history of lupus and was probably in a lupus flare. Those may have been contributing to some of these symptoms. She had episodes of worsening dysrhythmias while in the hospital, worsening heart failure, requiring to be transferred to the CCU. Now, as I said, she was having some other symptoms of a lupus flare, so I think the lupus flare was contributing to this. So you had systemic inflammation from one other etiology, if you will, that was contributing to her overall ischemic inflammatory milieu. This inflammatory milieu led to increased oxidative stress, led to more arrhythmias. Remember, we talked about the mechanism. More inflammation, more reactive oxygen species leads to more calcium influx in the cells, more arrhythmias, atrial arrhythmias and the like. That's what was going on with her. So we did consult some of my colleagues. We did get the arrhythmia under control with medication. She was in the CCU. And so the first team call was the structural heart team. We wanted to look at the mitral valve to see if we can get that mitral valve repaired. They deemed that the patient was too sick to undergo this procedure, and so wouldn't benefit significantly. I called my electrophysiology consultant to see if she would benefit from biventricular pacing to improve her cardiac output. She probably saw the structural heart team's note and said, well, this patient was deemed too sick to undergo this procedure. So to make a long story short, we had to call a palliative medicine team. They would consult to evaluate the patient. We got her on inpatient hospice. She was on vitamin C, diuretics, hydroxychloroquine for her lupus, and she was put on a milrinone infusion for the heart failure. She was on some other medications, Sotalol for the arrhythmia. And we were going to discharge her to a hospice facility. And we were told that they would take the milrinone infusion. However, within 24 hours of being discharged, they were not able to give the milrinone. And so the team was called back because of this, the palliative medicine team, and they recommended the patient be discontinued from milrinone in the hospital. A lot of patients die in the hospital. So I went and saw the patient in her room one day. She was crying and said, look, they're going to stop the medicine. And they told me I can order my last meal, have my family come and see me. So I said, well, let's try this. And I talked to the hospital case manager. I said, look, give us 7 days and we'll try one more thing. And so we tried on a nutritional detox regimen for a 7-day period. And over that time period, and I put on mostly smoothies with super greens like blue-green algae and other types of things. She did have a salad, but I had her on mostly smoothies because I didn't want to have her on solid foods because of her heart failure. She had some edema, probably intestinal edema, and probably would not absorb these solids very well. So after 7 days, we were able to wean off all of her medications except for one diuretic, Bumex or brometonide, 0.5 milligram only on an as-needed basis if she can weigh 2 pounds. So, and we'll take a look at her clinical data. Now, this is a little bit confusing because it went up and down. her kidney function went up and down as her cardiac function got worse. So when we stabilized the heart rate and the cardiac function, the renal function, perfusion got better. The creatinine came down. The creatinine went up when she went into arrhythmias and bounced around. This colored bar here shows when we start the detox and the kidney function sort of stabilized. And again, we were weaning her off of milrinone, which is a medicine that improves the heart function here. So her kidney function and therefore heart function stabilized. The glomerular filtration rate, same thing here. It goes up when the kidney function, the heart function goes up, and goes down, like when she's in arrhythmias and the renal perfusion is bad, up and down until we stabilize things. After the detox, it came up and stabilized at a normal rate. Notice that even though it's here, it's not as high as it was here, but she was on milrinone, a medication to actually, improve contractility, but we had weaned her off the milrinone as well as other medication. Lactic acid bounced around and stabilized, and we got some outpatient lactic acid levels that were normal after she had detox and had stabilized that area. Liver congestion. So the liver becomes inflamed when inflammation is built up. Could that be the lupus flare causing it to be inflamed? Possibly. Could it be congestive function or congestion from heart failure? Possibly. But either way, as we got a cardiac condition improved, this came down, and then the detox helped her stay down. ALT, same things, another liver enzyme. White blood counts. Interesting enough, after we detoxed, the white blood count went up before it came down. And you can often see when people detox, they can have a flare up before it calms down. But also, this is a sign that inflammation came down. The key thing with this patient is this: the medication list upon the initial discharge, when she went to hospice, she had 6 medications, one of critical, milrinone, hydroxychloroquine, keep inflammation down from lupus, diuretics, et cetera. After detox, she only went on 1 medication as needed. And I think the reducing the medication is important. Some of these drugs are metabolized through the kidney, the liver. And so the fewer medications, hepatically metabolized, the less stress on the organs such as kidney and liver, the better the person does overall. So the nutritional detox allowed us to wean her from medications and keep her hemodynamically stable. And not only did she get discharged, she went to home with home hospice and was able to go out and have a better quality of life. Number of medication went from 6 to 1. And I think that was a significant improvement. So in summary, key reason for the patient decompensation, I think she had a suboptimal plant-based diet. I'll talk about that a little bit in our discussion or Q&A session. She had severe mitral valve insufficiency. That was a main problem, but the atrial arrhythmias made it worse. But I think a lupus flare was probably feeding into this. And so making all of these things worse. These things have a negative cascade as they feed into, one feeds into the other. Cardiac conduction abnormality, the intraventricular conduction abnormality, I think, was also contributing to her problem. And again, the systemic inflammatory flare of the lupus, as I alluded to. Key reason for recovery, I think the nutritional detox was more central in her case than the other patient because we had nothing else. I mean, this patient was, left to die on hospice. And because of the detox, we were able to wean the medication. I think medication weaning in patients is very, very important. The fewer medications the patients are on, the better off they do because less stress of the organs, and our organs are already compromised. So the less we're stressing the organs, the better off.